Welcome to Day 2 of the 2021 Maryland Life Sciences Bioinnovation Conference. Please welcome the CEO of Maryland Life Sciences, Marty Rosendale.
All right, good morning, everybody. Good to see you back. So just a couple of things. We had a great day yesterday. I kind of want to fill you in on what we had going. So we had about 175 people here live in attendance, and we had 2,800 people that joined us virtually yesterday. So, clearly the conversation is great. The opportunity to interact is good. Our guest this morning is Dr. David Agus. Dr. Agus is one of the world's leading doctors and pioneering medical researchers. He is a professor of medicine and engineering at the University of Southern California's Keck School of Medicine and Viterbi School of Engineering. He is the founding director and CEO of the Lawrence J. Ellison Institute for Transformative Medicine of USC. A medical oncologist, Dr. Agus leads a multidisciplinary team of researchers dedicated to the development and use of technologies to guide doctors in making healthcare decisions tailored to individual needs. An international leader in new technologies and approaches for personalized healthcare, Dr. Agus serves in leadership roles at the World Economic Forum and other prestigious organizations, and he's also a CBS News contributor, which is where I first saw him. Dr. Agus' 3 books, The End of Illness, A Short Guide to a Long Life, and The Lucky Years, How to Thrive in the Brave New World of Health, are all New York Times and international bestsellers, and he's a 2017 recipient of the Ellis Island Medal of Honor. So welcome, Dr. Agus, please. Good morning.
Good morning. We have a grunt when you sit down. That's a scary thing, but yes.
So Dr. Agus, according to your bio, you're both a professor of medicine and a professor of engineering. Could you talk to us a little bit about what perspective that brings to you in the work that you do?
It's interesting. We very much get pigeonholed in what we do, and biologists become biologists, physicists, etc. But if you look in reality, in nature, these disciplines cross over each other all the time. So about 10 years ago, Walter Isaacson. So Walter he wrote the book on Steve Jobs, was head of the Aspen Institute, was the former editor-in-chief of Time magazine. He called me up and he said, listen, David, I want Murray Gell-Mann to interview you for a PBS special. Murray is one of the greatest physicists to ever live. Nobel Prize in 1969 when I was 4 years old. And I said, it's a little strange to have a physicist interview me. He goes, trust me. And he was right. Literally, in this hour interview, I had new ideas and approaches to cancer that we hadn't thought before. He goes, you always look at the median, look at the outliers. He would tell us about coarse graining and new ways to do models. And the notion of different disciplines is powerful. So I now run an institute where we have physicists, mathematicians, engineers to do that. I was trained as an engineer, which brings a very different perspective to biology and how I look at it. And I think in many respects, it allows us to be more innovative.
Mm-hmm. So one of the things that you said in your first book is it had to do with the importance of technology and biology in the future of healthcare. Could you expand on that a little bit?
Well, when we think about it this way, is that, first of all, I think doctors' offices are backwards, right? Mm-hmm. You go to your doctor's office, they draw your blood, they check your blood pressure, they get your vital signs, they do an EKG, and then they call you a few days later with the results. In many respects, that doesn't make any sense. We have to enter a new era where these data collection, if you will, happen first, and then you go to a doctor's office and you have a conversation. But we're now at a point where the omics have caught up, right? To do genomics, cheap, easy, very, very accessible. Proteomics, metabolomics, all of these omics now are becoming much more commonplace. If you look with COVID-19, we're sequencing, real RNA sequencing of the virus all across the globe. And we would have never imagined that before. There are devices where we're doing point-of-care DNA sequencing. For example, a company called Oxford Nanopore, where literally in the forests of lesser developed countries, you could sequence the virus and upload it to the cloud and in real time know about variants. This is a new world.
So you mentioned, we've got all the omics now, right? So there's a lot of different sources of data. But if you were to Google personalized medicine today, it's still going to focus on DNA and genomics. And one of the things I noticed, again, in your first book, is that you talk a lot about all those other different sources of data. When you think about personalized or precision personalized healthcare, how does all that fit in?
So it's interesting. I mean, you're right. We put DNA on a pedestal. It's one of the only things in biology we got right. We predicted it existed. We predicted it had a tertiary structure and it had that double helix. We predicted we could replicate it, and we had the PCR. It is one of the few things we as scientists got right, and we put it on this pedestal. It is a tiny piece to the puzzle. If you're going to drive, from Baltimore to Washington, D.C., and you take apart a car and look at every piece, it doesn't tell you how long it takes to get there. You forgot the weather, the traffic, the bladder size of the driver. They all matter. So DNA is basically taking apart the car. It is a piece to the puzzle, an important piece, but it is only a piece to the puzzle. And unfortunately, it's been what we say personalized medicine. Everybody thinks just DNA right now. And I do think that's a problem. I mean, listen, the pioneer and champion of DNA, Francis Collins, stepped down this morning. So is no longer head of the NIH. So for the last 12 years, we've had it led by one person who believed in one omic and one technology. And so I do think this is going to be a new era. Proteomics is what's going on a moment in time. It's that conversation in the body. Metabolomics is probably even deeper. And those have been difficult technologies with a lot of pre-analytic variability that I think we're getting better at solving now. And it's going to enable much more precision medicine going forward.
So with Francis Collins stepping down, when we got some interesting and pretty amazing things happening with the administration, what does that future look like, do you think? Where are we headed?
I was with the administration yesterday at the White House, and I think what's going to happen is we're going to start to see a liberation of data. One of President Biden's big initiatives was something he saw with his son. When his son tried to transition his care from Delaware to Texas, it was almost impossible to gather the records. There was a time actually where doctors were FaceTiming. I was there watching. They were FaceTiming to show records to Texas because they had no ability to transfer those records. They had no ability of taking his data because his data were pieces of paper, right? It wasn't structured data. It was PDFs and printed paper. And so I do think we're going to transition from an era of that to an era of structured data. And it's going to enable everything that your members are making and doing to happen an order of magnitude quicker. And so the challenge is we do it right. We figure out ways to de-identify data. We figure out ways to use data appropriately. We figure out ways to use real-world evidence. What COVID-19 taught us is real-world evidence matters. Clinical trials, the gold standard, but very close to that is the real-world evidence. And that should be used with development of drugs and therapeutics. For the first time ever, we saw a vaccine. This is initially the Pfizer vaccine with the V-Safe program. So this was a program that after your vaccine, you could enter your side effects and what went on. And we're able to actually use that data to get buy-in for pregnant women, for breastfeeding women and others. So using real-world evidence to expand the label of a therapeutic, that was novel, and that was crazy. We never collected the data a day a drug was approved. We stopped collecting data classically. So this was a whole new era, and I think it's going to be very positive for this field going forward.
So when we were just talking a few minutes ago, you mentioned that you led the team that built the V-Safe program. And the other day when we were talking, we talked about this need for real-world data. It's been a struggle in the past because others haven't trusted real-world data. How do you manage the integrity and avoid bias and those issues? Do you think that the reception is there now? People are more willing to accept real-world data? Is it because we're better at technology and controlling that data? What's going to drive this?
Well, listen, what's driving it is we're seeing when you use real-world data, you get better indications of side effects, of where it works, where it doesn't work. So patients benefit from real-world data. The challenge is to take these Cerner and Epic systems that we have that were designed so that I, as a doctor, could bill appropriately. They weren't designed to create structured data for real-world evidence, but to develop systems that enable us to do that, and it's very doable. We saw with the V-Safe and other programs is that we can start to use these advances in the cloud and technology to actually manage patients better, and so I do think it will herald a new era. It's going to be very, very exciting. Listen, I give CHOP chemotherapy for lymphoma, yet it's not FDA approved for lymphoma. We use platinum for germ cell tumors, and it's not FDA approved for germ cell tumors. So we can go, many of the things that we do in the real world are very different from what the indications are from the Food and Drug Administration. And so the real world, I mean, the challenge now is to merge those two together, and I think you're going to get a receptive FDA for that.
Okay, well that'll be a welcome change, I'm sure. So a lot of our members are developing technologies now, and they're trying to look into their crystal ball to see what this future looks like. What would you advise them with respect to how should they be managing their data? What should they be doing today to prepare for 4 or 5 years from now when their products are ready for the market?
All right, number one is move it to the cloud. I mean, what we're seeing now is that data is not secure. No matter who you are as a company, move it to the cloud and let literally professionals take care of it. We saw this week the first case where a hospital's informatics system was taken for ransom and a child died. So the first death attributed to ransomware happened this week at a hospital in the middle of the country. The second is structure your data. And so everybody says, well, I'm going to get all my data, I'm going to use machine learning and AI on it. Well, machine learning and AI thrive when the data are structured in a certain way. And so you need to develop not just data, but the right structured data to enable you to learn in the future. The third is start the conversations now with both the FDA and CMS around data structure. Is that make them be your friend in this regard. When they're involved in pushing new boundaries with you, you're going to get a much easier time getting it through. If you do this on your own and say, hey, I'm here to change the system, their shoulders are going to go up, and that's not necessarily a good thing. So work in partnership. I think you're going to see an amazing reception both at CMS and with the FDA to newer technologies, newer forms of using data structure to probably change indications for a device or a therapeutic. It's a new world there, but work with them, don't work against them.
So in your experience, so I've worked with both agencies, CMS and FDA. I've found them, on the most part, to be receptive, not always flexible. What are your thoughts? How are they going to change? How are they going to respond to these needs?
Well, the first thing we need as a country is a Technology Modernization Act. One of the issues we had during COVID was we tried to develop software to help with some of these agencies move forward. And we couldn't find any more COBOL programmers. I mean, much of our government is programmed in a language called COBOL that we stopped teaching several decades ago. And so we need a Technology Modernization Act. I do think now there are champions with everything each of you are doing within each of these agencies, and you need to work with the champion to be the poster child for what they are doing. We saw that with Amy Abernathy's efforts at the FDA to try to use real-world evidence and data. So getting her group to have been your champion would have made all the sense in the world. And I think we see that with each of the agencies now, and be a part of that. I mean, there are going to be people there who haven't changed with the times, but there are many people who are. Right now, we have agencies that are somewhat leaderless, right? We have an acting FDA commissioner. We've got, other agencies with, very good people leading them, but not very good spokespeople, and they haven't instilled a lot of confidence. I do think there's going to be a change over the next year at some of that leadership that will enable us to move forward in a more aggressive way.
Yeah, that'll be interesting. Certainly we need to move quicker than we have in the past.
Government move quick? What are you talking about?
Well, we have seen it in the last 18 to 19 months. So let's move back to your view, personalized medicine, healthcare of the future. There's a lot of talk about companion diagnostics and their role, and this is all about data and helping physicians like yourself make decisions. Help our members understand a little bit more what that future means to you as a clinician.
So right now, if I asked any of you, normally what it means is there's diagnosis, and I use some sort of diagnostics, whether it be a biomarker test, a genomic test, and others, helps me guide treatment, and I wait, and after 3 months, 6 months, I take a look, did it work or not, the treatment? The future is going to be, is literally at short intervals in between, look and say, is that patient going the best trajectory, or are they below that trajectory? And let's do an orthogonal corrector to get the patient up. So the notion of developing these technologies for discrete moments diagnosis and when we're checking for what we call restaging, whether for any disease, whether it be Alzheimer's, cancer, or others, I think is going to change, and we're going to start to do so much more frequently. And so the notion of being able to look at a short time point and make a corrector to get the patient back on track, rather than waiting till the end, is going to be a paradigm shift in what we do. And so we now have the ability of, literally having the patient do point of care testing anywhere and getting that information to the cloud and into the electronic health record of the physician, so we can start to do them more in real time, rather than now this artificial kind of come back in 3 months, which is what we do now. And so think of having your technologies, first of all, connected to the cloud, so that the patient can decide, because I think we're going to start to see more and more rights transition to the patient. The patient can decide, does that go to my physician? Which physician does that information from that biomarker, that test, go to? And when does it go, and how can I do that? So the notion of designing technologies only for the physician's offices, I think is going to be the past. And very soon, we're going to have these point-of-care devices. And it may be, if you run a big company with a big tower, if anybody ever gets back to work, that you may have a room there where someone can go, prick their finger, and get some of these tests. That information will go to their physician, and they can make that corrector before the patient actually comes in.
So this may be a bit of a provocative question, but do you think patients are ready for that? Are patients ready to manage their own data in that way?
I don't think they're managing their own data. I think they're deciding where their data goes. And I think those are different things. And I think a patient has a right to say, when you draw a test, I want it to go to the cloud, and then I decide if it goes to Jane, to Jim, and to John, and to my son-in-law also, who happens to know more about medicine than I do, and I want him to see it. And right now, it's literally gone to a piece of paper in the doctor's chart, or a PDF in Epic or Cerner, and we have to transition that.
Right.
And that part clearly has to change. The patients are in charge of their own data, and I think it's going to be easier to get newer technologies, newer biomarkers out there, because we're going to go to an era of patient education and empowerment like we've never seen before.
Yeah. No, I agree. It's going to be fascinating what we see with respect to new data. I mean, here in Maryland, not only do we have a large technology and data community, but we also have one of the largest clusters of developing quantum technologies as well, which I think are going to have an impact on that. Let's go back to COVID-19. And
I'm against it. I took a formal stand.
I think we're all against it. But let's go back to the lessons learned, right? So with this pandemic, with COVID-19, we've seen the government move faster. We've certainly seen, right here in Maryland, we've seen our companies come together, collaborate, form coalitions, and develop diagnostics, vaccines, therapeutics at a very rapid pace. What are the lessons that you've seen that we've learned through all of this that may persist going forward?
I think a couple are big ones that are important. Clinical trials we screwed up on. So initially, the clinical trials and the therapeutics, we said, let it be a free-for-all. Anybody could do any trial. And what we had is almost 2,000 clinical trials across the United States, all competing for accrual. You look at what happened in the United Kingdom and Europe, where they said, hey, let's put a hierarchy on what we think is the most likely drug to work and go down the road, and then we'll put them in, and the entire country will do those trials, bang, bang, bang. And same contract, same clinical trial design, we just slide in new drugs. That was a brilliant idea. Most of our advances in therapeutics came from that. So I do think you're going to have more of these boilerplate-like trials where you've got a group of institutions and you can plug your therapeutic in and maybe plug your therapeutic in a second time with a different design or second time with a different companion. But we don't need to change the contracts, the institutions, et cetera. That plug-and-play concept enabled much quicker and better and larger clinical trials, number one. Number two is, what we started to see also was that the day a drug was approved is not the day to start stopping collecting data. So continue on, whether it be with registry or real-world evidence, and start to collect more data. Because as we all know, clinical trials aren't necessarily how drugs are used. And so I do think there will be now, post COVID, more reception to doing that in big senses. The other is, I think, it's not just what you do, it's how you do it that matters. And so many companies have very good diagnostics, very good tests, very good therapeutics, and they're not good at explaining where their use is. They're not good at explaining and giving a sense of what the future is. What we've learned now is that you have to get better at telling a story. And so the notion is, I have this drug QS93287, and I'm going to see if it works in cancer or not. Those days are going to be over. People want to understand the story. They want to know how a drug is designed to work. What are the endpoints that are going to matter here? Where it's going to hit today, tomorrow, and down the future in terms of indications. And so you have to be better at telling that story. And when you start to look at the companies, many of the therapeutic companies and the diagnostic companies have never met or talked. And the therapeutic companies start and say, hey, listen, I want just the biggest market I can. I'm going to do all comers with advanced cancer, with advanced Alzheimer's. And what we're going to start to see is that when you start to tell a story and you have a biomarker that makes biologic sense, that can give you a higher response rate, you're going to do better and quicker get that product to market, and then let the market expansion happen in the real world rather than you doing it almost artificially with a broad market in your clinical trials. I think those days are going to be over. So I think the marriage of diagnostics and therapeutic companies have to happen, and they have to work together.
So help our younger, smaller companies out a little bit here. So telling the story, you mentioned the story between the diagnostics companies and the therapeutics companies, but there's also a story for clinicians. There's also probably a story for the public, certainly a story for investors. Who are all the audiences, and do the stories change depending on the audience?
You know, I think in reality, it's one story for all. I think the level of depth of the story does change, but I think it's important. You know, Amgen was third to market with an EGFR targeted therapeutic in Europe. And normally third to market in Europe, where price takes into account, doesn't go anywhere. But what they had done is they take out the people who had, and believe me, they'd taken years before they did this, but they took out the people who activated RAS, because EGFR was here and RAS was down here. So they were able to get a higher response rate. And literally, 53 days after they were turned down in Europe, they were approved, and they became dominant market share in many countries because they were able to have a higher response rate. And so the notion of thinking these things through and telling a story matters. And people don't get that. Again, there's still this very, very short view of, I want the biggest market I can so I can tell my shareholders, hey, when this gets approved, I'm going to get 10% of the entire colon cancer market. So therefore, I need a $7 billion valuation today.
Right. Yeah, that's always an interesting dilemma. So when you're thinking about that, so I hear often from new entrepreneurs something to the effect, or some spin on, if the rest of the world only knew what I know, right, they'd be lined up at my door. and that education is a transfer of knowledge, but sales or storytelling can be a transfer of passion and enthusiasm. Is that part of what you're?
No question, but you have to realize, everything is in context. The context of today is value-based care is going to happen. We are going into that era. So if you have the coolest, brightest, shiniest object, the old days, that would get you funding. In today's world, you have to show me, listen, I can find circulating DNA of cancer. And does that mean that this diagnostic is going to be used for every cancer patient in the globe? No. You have to show me it changes outcome. Right? I don't just have to identify something. I have to change outcome, which is what can be translated to value. Value for the patient, value for the payer, and value for the system. If you can't show those things as part of your story, I don't want to play with your technology. And that's the problem now, is a lot of people are showing bright, shiny objects, and they're not really showing me where that value is. I don't want to know, listen, if I have one choice for third-line liver cancer, do I need a biomarker whether to give that drug or not? That may tell me 86% who will respond. If it's not 100, I don't want the biomarker because I have no other drug to use. I want you to go to a point where I can turn left or turn right, and you help me decide whether to turn left or turn right. I don't want to go to a point where I only have an option of a left turn, and you tell me better numbers to make that left turn. That's not going to help me.
So that's interesting. I have a lot of those conversations with companies as well. If their diagnostic doesn't result in some information that will cause a physician to make an alternative decision, then there isn't a lot of value. But you used the phrase value-based healthcare. We've been hearing about value-based medicine, value-based healthcare for years, but you're talking about it as if it's right on the horizon. We're almost there. explain that a little bit.
The difficulty with value-based care historically is, first of all, nobody could define what value was. We had systems where if you sat with me in my electronic health record, you'd be aghast. First of all, it's like, MS-DOS from the 90s and how it's designed. And then second is, I just choose whatever diagnosis makes sense at the moment. I don't really try to put truth in for my billing codes because I don't need to. But as we transition to electronic health records being efficient tools for billing to being efficient tools for management, what we're going to see very quickly is that it's going to be real data, and we can start to quantify and make decisions with actually dollars attached. So if you give me a T-cell therapy, a targeted CAR T-cell therapy that wipes out all my B cells, it's not just the cost of the drug, but it's the fact that I need intravenous immunoglobulin for the rest of my life that will go into that cost, and we're making that decision about what is real value here. And I think that's going to be critically important as we go forward. And so one thing you have the administration saying now is, I want to put more resources into drugs that offer value and less into ones that don't. There's a reason, Roche bought Flatiron. There's a reason you're seeing many of these companies buy analytics tools because they want to start to realize what value is for their therapeutics, design the clinical trials, not just that show efficacy, but also that show value. And that's a very different optimization parameter. When you're a testing company, when you're a therapeutics company, you need to have economists who work with you to help design your trials and put your models together so you have the data to rationalize why you have value. Not to shy away from it, but to take it head on. Because when there's an inflection point, and there is an inflection point coming, and we're going to start to see, believe it or not, CMS and the FDA starting to talk, when that starts to happen, you can either succeed wildly or you'll fail. You succeed if you know what's going to happen and you design your system for that.
So past administrations and even this administration somewhat have focused on drug pricing. Are you suggesting that we should stop focusing on pricing and focus more on overall value and pharmacoeconomics?
Oh, 100%. Yeah, I mean, absolute pricing is meaningless. You're going to need to rationalize why you price. And it's not going to be necessarily predatory. Hey, I'm the only drug for third-line, colon cancer, therefore I price whatever I want. That's a predatory practice. And so you're going to have to show how you add value there. And I think it's totally doable. I mean, good drugs are going to thrive and do better in this value-based era. Poor drugs aren't. And so how you design your trial, when you design a trial, how you do symptom management is just as important as how you look for efficacy. Because if you can reduce symptoms, and we can reduce most of the symptoms in a trial, if you think of it prospectively, then you're going to get better value there. You're going to get fewer ER visits, fewer doctor's visits, and that equals value. So you have to think like that. The old days it was, just put in whatever, and we'll once we have all the data, we'll then design some system to help manage side effects. That doesn't fly anymore. You do it prospectively, and you're going to get numbers that equal value.
So, and we talked about this briefly the other day. Pharmacoeconomic data has been a struggle in the past. We've tried to use, many of us have tried to use it to justify the value of our technologies or our products. But it sounds like to some extent you're suggesting this is partly based in pharmacoeconomic data, partly based in clinical response. I mean, it's more than just pharmacoeconomic data. That's the point I'm
Oh yeah, I mean, listen, we designed a system, for example, that at MD Anderson, where we piloted it in Houston, Texas, every patient on particular regimens, we chatbot with them every day. So basically they say, how do you feel? And we've developed a structured database for these therapeutic regimens where we know every day, so cycle 3, day 2, they start to have real nausea. Cycle 4, day 2, we give them an extra dose of an antiemetic and they're not hospitalized. And the results were actually published in JAMA recently, Journal of American Medical Association, showing fewer ER visits, doctors love it, and it's triaged, is that now with machine learning, most of them can be handled automatically through a chatbot, and it only gets escalated when it hits a certain level. So actually fewer calls to the doctor. Doctors thought they would be barraged. It's actually the opposite. And at the same time, we have a structured database, so we can actually design regimens now so we don't get ER visits and calls and hospitalizations. We prevent these side effects because we didn't know them before. Shockingly, we didn't know when they had nausea. We didn't know that if they were large or small, they would have slightly different incidences of when that nausea kicked in. If they were, lived alone versus lived with somebody, they would have slightly different outcomes. And now we have all that data. It's all fine-grained. It was developed with a chatbot, so it cost almost nothing to collect it. And we've had that, and it guides the management now at MD Anderson.
So let's talk about that for a minute, because I find that fascinating. So you've got what must be massive amounts of data, and you've got direct experience because these are your patients that you're collecting this data on. So part of this is because you've experienced the response and you're collecting the data. But if another physician came into the practice, for instance, do you have the mechanism to analyze that data so that physician can have the same benefit from it that you do?
Oh yeah, I mean, so that system MD Anderson is now at every physician MD Anderson uses. So the largest cancer center in the country is deployed across all of them. Mm-hmm. And what we also have from that is we have outcomes to care. Mm-hmm. So if there are 30 docs that are giving a chemotherapy regimen for colon cancer, and one of them has a higher hospitalization than the other, we have to look into why. It may be that doc gets the sicker patients because they're the better doc in respect, or it may be that they're really not as aggressive in symptom management as the others, and we have to educate them, and then it'll come down, because in the end, that will lower costs. And so having dashboards where you can start to look at outcomes in a predetermined way changes everything. And that's where we're going to go, right? If you're not within a standard deviation of the outcome of your community, then we're going to pay you less. If you're at the standard deviation, we're going to pay you 100%. So again, we're going to have pay for play here, pay for quality. That's where things are going. We now have the informatics tools to be able to do it. The key now is to start to deploy them. And that's what you're going to see over the next 1, 2, 3, and 4 years, is a pretty rapid deployment of some of these tools to enable that to happen. We haven't had those tools before.
Okay, so I'm trying to put this in the perspective of some of our younger companies and how they should be looking at this. I mean, we're talking about large amounts of data. Mm-hmm. Do they need to hire a computational scientist to be on their team? How should they be managing it?
The way most of these are worked is, for example, through an entity called Project Ronin, we created this whole chatbot entity. Mm-hmm. And so we just give the analytics to the pharmaceutical companies or to the biotech companies because most of the time they don't have the teams to do that. And it becomes just dashboards. Mm-hmm. And so you help design a dashboard with your metrics built in. And then you get that dashboard that has your readouts, and that dashboard can be part of your filing, part of your monitoring of the drug, part of your post-approval surveillance, any of the places you want it. So it can be relatively easy. We're not training a lot of people on the statistical biostatistics. We're not training the machine learning talent that we need in this country, so it is in short supply.
Mm-hmm. So I just want to take a minute and remind our audience that's watching us through the virtual conference platform. We do have a Q&A function in there. In a few minutes, we'll get to the questions and answers. I am monitoring. I've got the technology. I'm monitoring those questions here. And so please feel free to post questions in that Q&A section. So Dr. Agus, let's come back to the future. You advise leaders all over the world about the future of healthcare, where it's going, where it should be going. What advice are you giving those leaders that we ought to know about?
So what's really interesting, if you look at countries like Africa, I chair the Global Health Security Consortium with Tony Blair, the former Prime Minister of the UK. And so with some of these systems in Africa that developed a cloud-based system for registration where they would use the face or a fingerprint. Mm-hmm. And so a patient would come in, they would develop an account in the cloud, and they would get an alert on their cell phone, hey, it's time for your second shot to come back. Systems that basically leapfrogged what we did here with our paper systems in the United States. And that's transitioning to becoming their entire healthcare system. So initially it was their adult vaccine programs. Then it became their whole healthcare system where they would have a cloud-based account based on some biometric ID. And you can envision that person in Ghana, for example, one of the places we put it in, they can go to any hospital in the country and they know everything about them. You try that doing here in the United States and you'll pull your hair out, or whatever I have left of it, you'll pull it all out because it's almost impossible to do. Mm-hmm. You have to get your doctor to fax all your records somewhere, or you have to go pick them up yourself and physically bring 400 pages in no order to a doc who has to go sit and read through them for an hour to figure out what's going on with you. So we have to change that. We have to transition to the cloud with these healthcare systems, and that will happen, and it has to happen. We have to develop global standards. Mm-hmm. And we've never done that before. So we wrote a piece in the New York Times last week where about travel. Right? We've approved 3 vaccines through an EUA, so emergency use authorization in the United States, and 1 with full approval. Well, what if someone in the United Kingdom had AstraZeneca vaccine, which is a very good vaccine and it worked against Delta, and comes here? Do we allow that? Do we count them as vaccinated? Or do we say all vaccines? Somebody had Sinovac in China. It does not work against Delta, or Sputnik V doesn't work against Delta, and they came here. Do we treat them equally? Who makes those decisions? We don't have a group that makes those kind of collective healthcare decisions, and that's a problem. You know, about 6 years ago, I got a call from the New York Times that said, hey, listen, Angelina Jolie is going to write tomorrow that she has this BRCA mutant. She has a mutant breast cancer gene. Will you write the companion piece? I go, sure, when is it due? And they said an hour. So I wrote about it. Then in the 90s, there was a team that was given $26 million from the government, and they went to the Mormons because the Mormons all wanted to be buried in the church in Salt Lake City, and they couldn't fit. So they had their hair and their history there. So in 100 years of DNA, they identified the gene. It went to a company that were bankrupt. Another company bought the assets, and they charged $6,000 for this test. So in a sense, it was predatory and monopolistic because they just chose an arbitrary price for this test. And many people couldn't pay that ransom to look at their DNA. Well, about 3 months later, the Supreme Court said, we have now said you can no longer patent a gene in our country. And one of the justices called me and said, aren't you proud of us? I said, it took you 11 years to do so. So in today's world, where we're having technology innovations daily, where AI is changing things like we can never do before, automating our tasks, being able to say who's high risk and low risk, we need transparency there. We need many things, and when the systems like our Supreme Court, our legal and ethical, take years to respond, it's not going to work. So we need a new system to respond very quickly to the changes that are happening. We would never had a time in the world where things happen this quickly.
So at the risk of potentially getting a little political, who should determine who's on that panel that sets the global standards so that the world trusts what the standards that they're setting?
Well, right now we have the World Health Organization, and the problem with it is one vote, one country. Mm-hmm. So you're saying, you know, a small country, a developing country is the same power as the United States, as the United Kingdom, as China, and that's just not going to fly in today's world. So you need to set a higher authority, and we're working with both the G7 and the G20 to be able to do that. And I think we're going to have to do that. And it has to be global. Listen, if I set restrictions in our country on using CRISPR, and all you need to do is go to Mexico, and then you can use CRISPR all you want and then come back here, well, that's exactly what happened, where we had an obstetrician from New York who went with a woman to Mexico and did things and then brought the woman back and delivered the child. Here, that's totally legal. That can't fly in today's world. Mm-hmm. So this has to be global, the governance, and we're trying to put together such organizations.
Okay. So I'm going to ask you to take off your physician hat for a minute and put on your engineering hat. We've talked a lot about data this morning. What are your concerns about the security of that data?
Major concerns. I will tell you, having sat with governments over this last 19 months, is that many of you who think your computers are secure, they're not secure at all. We were able to see foreign governments, you know, who had data from many of the pharmaceutical and biotech companies, some of which are probably in the room today or online today, and they were able to just look into their computers and they know exactly what they're doing. So security is paramount in today's world. And you have to figure out a way. Your local IT team is probably not as good as some cloud-based provider who all they do is live, eat, and drink security of data. And so we're a new world in that area. I mean, hackers have the ability of doing almost anything. As we saw yesterday with Facebook and Instagram, it ain't by coincidence 60 Minutes does a story on Facebook, and that day, Facebook and Instagram, their websites disappeared off the internet. Mm-hmm. So literally disappeared off the internet. And they had pretty good security teams at both of those, and they were gone and slowly coming back up. And so I will say is that, you know, having worked with governments, I'm astonished now about who is looking at what and how easy it is to do so.
Yeah. So we have a large cybersecurity cluster here in Maryland, probably the largest in the world. Yet we still find that each company is in a battle all by themselves against nation states that are attacking them. What are your thoughts about, is there a way for us to come together as a country or a region and protect ourselves in a broader fashion, or is it always going to be one company versus the world, frankly?
Well, I think what we're seeing is an evolution to several cloud-based providers who are very large, who are working with governments on the security side. It's very hard to do it on the smaller companies. So I do think many of your cybersecurity companies are remarkable companies that are a part of that and probably work with many of those providers. And I think that's where it has to go. The old day of, I've got my IT man or woman, and I've got my computer cluster here, and this is everything that runs our company. That's not going to fly. It's not going to fly at hospitals. It's not going to fly at healthcare institutions. It's not going to fly at individual biotech or pharmaceutical companies. It just can't. What's in your computers is too important for the citizens of our country and for the globe to let it be hacked.
So, Dr. Agus, I feel like I've jumped all over the place this morning as we've been talking, because you just got so much information that I find fascinating. Is there anything that we haven't covered this morning that you think our audience ought to be aware of?
No, I think, listen, we are still, unfortunately, in this pandemic. And so, what we're seeing is, we thought we were out of it once, and Delta came along. And over 1 million years of evolution, our genome changed 1%. This virus can change 1% in a day. And so literally at a moment's notice, we can have a new variant that comes out. Either happen organically through nature, which is more likely, or there are countries now that are trying to actually manipulate the virus for their own gains, and I think that's very scary. And so, certainly we're at a pivotal point now. In the United States, we have to get vaccinations rates up. We're going to see a point in the next couple of weeks where we're going to start to vaccinate kids 5 through 11, which is another 28 million kids on the roster, which will be very helpful, because obviously kids at school is a vehicle for spread. But we need to get the vaccination rates up, and I hope every company involved here is really pushing for vaccines at their own company. But it's in our interest, in the United States' interest, to vaccinate the globe. If there's a country with no vaccine and the virus spreads, that's where a mutant can happen that could lead to a new variant of concern, and we're back where we started. Israel published a paper about a year ago showing that there were 3 possible mutations that could avoid the current vaccines. It was withdrawn for security reasons the day after it was published, but obviously that's something that we all worry about, is that if this virus evades the vaccine, we saw it, right? Delta required a higher level of immunity because some of the points that the vaccine immune response targeted went away, a higher level of immunity, which is requiring us to do a booster shot. The booster is initially in Israel, now most of Europe and here, and we need that high level of immunity to be protected from breakthrough from Delta. We're worried about another variant, and so we all have to be on our guard, change our way of doing practices, and really develop a new normal. And it's going to be incumbent on every company as part of their practices. You don't want to slow down your research. You don't want to slow down your product, your projects. Clinical trials in all areas of the globe halted for 18 months because of COVID. We don't want that to happen again. So we have to COVID-proof ourselves for the future also, for whatever that virus is. We had 8 near misses over the last decade before COVID. One of them had a mortality rate of 80%. So there are going to be other viruses that come on board, no question about it. We have to get ready.
Yeah, so that's the biggest fear, right? We're going to have a pandemic, a virus that has a much higher mortality rate. I happen to sit on the steering committee of a group that's come together, a really amazing group of people that have come together and are proposing the formation of a global pandemic prevention and biodefense center. Initially, the focus is on a project that's been called Ahead 100, which is focusing on pre-producing, if you will, developing and producing monoclonal antibodies to the top 100 pathogens likely to cause a pandemic. If you were advising that group, looking ahead, and the purpose is to prevent the next pandemic, what advice would you be giving them?
Number one is monoclonal antibodies is not a scalable technology for the globe. You can't make enough of them to help on a global basis. Billions of doses, very hard to do. I think nationalism of production is a major issue. We saw that in India with Serum Institute. We saw that in the United States and elsewhere. We saw that with GSK, that has something that was manufactured in China and had issues because of that. So I do think we need to do nationalism-free zones of production, and we need to start to think in how we do that. So it is cannot be taken over by that host government if it's produced in those areas, which really, really scares me. I think we have to put a lot more work into newer ways of doing production. The U.S. government took over the Merck vaccine production plan. We still haven't gotten doses from there yet, and it's been almost 10 months or 9.5 months. And so it's hard to scale up productions on the vaccine side, on the therapeutic side. It's hard to make a 100,000 liter bioreactor for antibodies. Very, very difficult to do on these large scales. We have to figure out better and more efficient ways of doing the production. We have to work on our supply chain so it doesn't become an issue. And small molecules have to be a part of the equation. Small molecules, easy to produce. We can scale their production, easy to transport and store, much easier than something like a monoclonal antibody. Believe me, I love monoclonal antibodies, and they clearly have their role. But as we've seen now, we still don't have monoclonal antibodies where we need to. We had AstraZeneca file today, I think, with their antibody. Well, that antibody, you know, I talked to them literally in April, you know, a year and a half ago, and they were starting to have, and look where we are now. It's taken too long for that development. So you can have all the good intention and the greatest product in the world, but if development is going to take that long, it ain't going to help like we need it.
Yeah, and I really strongly agree with that. I'm excuse me. I'm hopeful that one of the outcomes of this pandemic center, should we succeed in pulling it together, is that all the development work is going to show us new and better ways to scale manufacturing. And in that way, we'll be ready for the next pandemic.
Yeah, I mean, this is the big benefit of, believe it or not, one of the biggest benefits of RNA is that you know the production yield. Right? Conventional vaccines, antibodies, we don't really know the production yield all the time. The beauty is you know the production yield with RNA, and you can do that, and it's a much smaller footprint for production, which may make it easier in many regards.
Yeah, cool. Well, we're down to the last 10 minutes, and I've been monopolizing your time. Do we have any questions from anybody in the live audience? Well, while we're waiting to see if there will be any questions, I am curious. So when I realized I was going to get a chance to talk to you, I got your first book. I haven't read all three of them, I have to admit, but I did read your first book, and the title of your first book is An End to Illness. Do you truly envision a time when that will happen?
So when I wrote that first book, it was my first book, I didn't know what I was doing, and I called it What is Health? It was an homage to a scientist named Schrödinger who wrote a book, What is Life, in the 1930s. About a week later, I got a call from my publisher who goes, David, Steve Jobs called and he changed the title of your book. I was like, what? And I called up Steve, and I was privileged to care for him at the time. I go, what are you doing? He goes, David, you can't put the word health in the title. It implies eating cauliflower and Brussels sprouts. Nobody will like it. Plus, you can't give a gift of somebody a book with the word health because it implies the other person's in bad health. I go, why would you call the publisher, not me? He goes, well, they're responsible for marketing your book, not you, correct? I go, yeah, I guess. And he was right. I mean, the year the book came out, it was the most gifted book in all of Amazon. I mean, Steve knew marketing and branding. Do I think there'd be an end of illness? No. Do I think we can delay and prevent almost every illness? Yes. And I think that's where we need to put our resources and focus on. You know, it's very different when someone develops an aggressive cancer at age 95 than if they do at age 50. And obviously, the amount of resources we as a society put there, the amount of suffering, et cetera, is very different in those regards. And so I do think we have the ability of delaying and preventing many cancers, Alzheimer's, heart disease, et cetera, and we're just not doing it. We say in our country, do whatever you want, sit all day, smoke, be as large as you want, and then we will pay for the healthcare ramifications of your behavior once you turn 65. That has to change. Right? In Singapore, if you skip colonoscopy and get colon cancer, you pay a $63,000 surcharge before you get treatment. If you smoke and get lung cancer, you pay a $91,000 surcharge and then you can get treatment. In the United States, we don't do any of that. You know, there's a pill that's 2,433 years old that if you take it every day, you reduce the death rate, not the incidence, the death rate of cancer by 30%, heart disease by 22%, and stroke by 17%. This pill, Hippocrates said, you take the bark of the willow tree and chew it, pain and fever go away. It's called a baby aspirin. Yet most people in this country don't take it. And so we can go, you know, treatment by treatment that we know works preventatively. And so we have to say, listen, if you don't do this, you have to pay a higher insurance premium. We're seeing it now with COVID. If you're not vaccinated, insurance companies and many companies said, you have to pay a higher premium, and we're not going to pay for your care if you're admitted to a hospital. Well, that radically changes things. We have to do that across healthcare.
Mm-hmm. Yeah, I know historically we've tried to focus, many people have tried to focus on healthcare versus sick care, well-being. but it doesn't seem like it's taken off as well as it should. I mean, I know a lot of people who feel like I can do whatever I want today because tomorrow there's going to be a pill to fix it. And I agree. We need to get better at that. Just want to take another quick look around the room. There we go. We have a question here.
Good morning, and thank you for being here. My name is Lynn Bencion, and I'm with Montgomery County Economic Development Corporation. Very different topic that I'm going to ask about. The family of Henrietta Lacks has filed a lawsuit to benefit from their ancestors' cells. I wonder if you'd like to comment about that. Thank you.
So, Henrietta Lacks, remarkable woman with cervical cancer, her cells became the HeLa cells, HE and LA from Henrietta Lacks. And they filed a lawsuit against Thermo Fisher, who is selling these cells. And I don't think it was for their benefit. I do think actually the money was intended to go to a philanthropy or charity to fund, to benefit others. And, you know, there have been several of these cases that happened over the years. There was another very famous one with California Regents versus Moore, where the first cytokine, GNCFF, came from a patient with hairy cell leukemia, and the doctor consented the patient, took it. David Goldie was the physician at UCLA, and it was discovered there, and a company came from it, and that's how GNCFF came to bear. And years later, the patient sued, and actually LA Law, if you remember that show from the old days, if you're old enough, LA Law did an episode on it, and the day after LA Law, the patient called and had the same settlement that was on LA Law. And, you know, these things were done in an era where patients didn't have rights in that regard. Now you signed a consent saying if any tissue is used, it can be used for profit or not. You have that decision to make. Henrietta Lacks did not have the ability to make that decision. And a remarkable book was written about it and became an important cause for that discussion. You know, I do think, you know, now this is not going to be an issue going forward. But when you look backward, I think it was an issue, and I think something should be done with the proceeds of those cells, and it should be going to a foundation that actually enables better care for people who potentially suffer for things, or for something that actually Henrietta Lacks would have cared about. I think makes the most sense. And yeah, I think these issues, you know, whenever you have something like this that makes the media, what it does is it causes discourse. And I love the discourse on it. You know, my children now know who Henrietta Lacks were. They know what HeLa cells are, and they never would have without this discussion. So I think that's the big positive to me, rather than the financial side, is that it did create a discourse because of that book. And I think it was a fantastic story that needs to be told.
So I have one parting question for you. Again, coming back that you advise leaders around the world. Can you tell us, when you're talking with those leaders, with our global leaders, about healthcare and the issues that are being faced, what's their primary concern?
You know, the sad part is that, no offense, you know, most politicians I don't like. And because they think of things in terms of their cycle. Over and over again, I would hear from a politician, a governor here, a mayor here, a head of state here. Well, David, everything you say makes total sense, but I really can't do it because it'll piss too many people off. And I'm running for re-election in 16 months. Or I need that constituency to get this done. They didn't say what is best for the citizens of my country. And the problem with healthcare, 31% of the U.S. economy, and yet we have no real leadership here. Healthcare does not go in 4-year cycles. Technology doesn't go in 4-year cycles, yet politics does. So we need to find a way to rise above the fray of political decisions and have a clear road forward with healthcare. To get normative behavior change, you need leadership, and we don't have that leadership on the healthcare side. You know, if I say to any kid walking in the street, who's a healthcare leader? Well, now they may say Dr. Fauci, but until then, they wouldn't have come up with a name. And that's a problem, right? A third of the economy, and yet we have no real leadership in that space. And that's a real issue here, is that we need to start to develop leadership so that we can have the longer cycles. And that needs to happen globally. Every country really needs to start to put forward leaders on healthcare to enable the right change, to enable people to believe in science, to believe in data, and to believe in the future. If you have hope about your future healthcare-wise, you're going to have a much better economy and have a happier country. And that's the message to most of these world leaders.
That's great. So, Dr. Agus, I've really enjoyed our conversation today. Thank you so much for your time. Thank you for everything that you're doing. The advice that you're providing our leaders is tremendously appreciated. Thank you.
Well, listen, it's my privilege. Obviously, the companies within this Maryland Corridor are some of the best and most innovative in the world. I was born in Baltimore, so I'm a fan, obviously, of this area. And thank you all for what you're doing. I mean, you are the future, and we need all of your companies to succeed so we can succeed. So thank you.
I forgot to mention your nexus to Baltimore. Thank you.